So here you're seeing the steps of fracture repair. So we just talked about what happens when bones fail us, or really when they are hit at angles or receive trauma that is in opposition to the way that they're built to withstand. So the first thing that happens, just like with a cut, just like with any other kind of injury, is inflammation, and here there's also the formation of a hematoma. So with the inflammation, you're going to see redness, heat, swelling, definitely pain, and that fifth sign, which would be immobilization. So the pain and the swelling lead us to immobilize the area or not use the area to prevent further damage. And in this case, that further damage might be the creation of an open fracture where the bone comes through the skin, and then infection is a really big consideration, an unfortunate consideration, as well as potentially fat emboli that can go into the blood and then block pulmonary vessels. Within a week, we get the formation of a fibrocartilaginous callus. And the purpose of this fibrocartilage structure that you'll see here deep to the periosteum is to connect the two ends of the bone so that now we can work internally and set down functional, healthy, well-organized bone tissue. As soon as that callus is formed, a bony callus forms. The bony callus forms when chondroclasts clean out or degrade this fibrocartilage, and immediately will put in osteoblasts that begin to lay down the collagen fibers and the proteoglycans of the matrix. And then we'll also see some of those differentiate to osteocytes. While all of this is happening, you can see over here on the left and then a little bit over here on the right, you're getting areas of bone that's not well organized and certainly doesn't fit the shape of the original bone. So this is where osteoclasts will come in and they do some remodeling. They're going to break down these extra pieces of bone here and the extra pieces here so that we have a bone that for the most part resembles the original bone. The biggest difference that you'd see, and this process can take a couple of months if you're young and healthy and well nourished, I shouldn't say young, but if you are healthy and well nourished, to many more months depending on your state of health. If a person's protein deprived, this can take much longer if it ever does work effectively. And what you're going to see if you were to x-ray this bone is you'll see a bone scar or the remnants of a bone callus that tells us that this area was broken, but now it's not just fixed, it's fortified, meaning that it's even stronger. So there's an old wives' tale that says if you hit a bone or break a bone in exactly the same place, that it will break in exactly the same place. And that's not really true because the bone's actually stronger post-break. You may fracture the bone in an area that's very close to the original, but generally not in the exact same place. So lastly, we're going to talk about a couple of bone disorders. So we'll start with osteomalacia. And osteomalacia is a bone condition similar to rickets in which the bone becomes less dense, becomes softened, so less dense, less calcium phosphate matrix. The malacia part refers to softening. And here you can see a picture of real normal bone and real bone that has osteomalacia. So generally, like with rickets, which is what you'd call osteomalacia in a young person, in a child, you'll see that the person has a lack of calcium in the diet or a lack of calcium for something like celiac disease, which is a gluten allergy. So the food that the person's eating is moving through the intestines too quickly to be absorbed, or there could be structural damage to the intestines, which prevent the absorption of calcium. Kidney or liver dysfunction. So why kidney or liver dysfunction could be a very, very long answer. One thing kidneys do for you is that they're supposed to conserve calcium from the blood when they're filtering, and an anti-epileptic or an anti-seizure medication would force the brain to use, and the neurons, to use more calcium for neurotransmitter movement or neurotransmitter release, thus depriving the bones of that calcium, or forcing osteoclasts to break down bone to fulfill those calcium needs. So this is an x-ray of a child who has osteomalacia, but in the child we'll call it rickets. And the way that I can tell it's a child is because I can still see the epiphyseal plates in the femur here, and in the tibia here, and here, and here, and just a little bit right there in the fibula. So what you can see is when this child started to stand up and walk, that because the bones weren't fully mineralized, perhaps it was a lack of calcium or a lack of vitamin D in the diet. In the case of this child, she's from a country in which dairy and calcium-rich foods aren't really a big part of the local cultures. So that's not the only reason, surely, but that's potentially one of the ones in this case. So you can see, especially with the tibia, that the epiphyses have moved laterally here and laterally here, as well as the fact that the tibia, which should be straight up and down, and most definitely over here should be straight up and down right about here, has bowed, because with the weight, the bones will bow. They'll bend under that weight if they're not well mineralized. So we'll turn to osteoporosis now, which is a condition that affects quite a few women, especially women of Asian and Caucasian descent, because it's thought that those women statistically have less dense bones than women of other ethnicities. A few other risk factors for osteoporosis, which would be the decrease in bone density, particularly in the trabecular bone, and you can see that here, normal healthy bone on the left, and then bone where you can actually see where some of the trabeculi have broken off, and you can also see it's quite a bit more holy, if you will, quite a bit more spaces than trabeculi of bone. So more of those risk factors would be having a small body form. So when we say that someone is sort of petite, they are short, they have small bones, not necessarily thin, but the bones are thin. Being sedentary or not moving for long periods of time each day, because the way that bones get stronger, according to Wolff's Law, is that we stress them out. So the more we use the bones, we create these microscopic fractures, and the body doesn't just fix those, it fortifies those, and that's how we build up bone density. If we don't have the raw materials, calcium and proteins, to make calcium phosphate or hydroxyapatite and the collagen fibers, the proteoglycans that make up the matrix, then we can't make bone. Smoking is another risk factor because the chemicals in smoke are ones that cause mutations in the DNA. So expressing the DNA, making proteins that are effective, compatible, and healthy can be degraded, as well as depriving the body of oxygen to make ATP for bone growth, as well as producing chemicals or intaking chemicals that will also degrade proteins themselves. Certainly a few other, just a short list of a few other conditions. If a person has an excessively high thyroid rate, that is hyperthyroidism, so excessive thyroid hormone production, that imbalance may lead the body to build up heart muscle, say, instead of bone, or to build up the liver to focus on the kidneys instead of focusing on bone. Now, Paget's disease is a disorder that is kind of the opposite of osteomalacia and osteoporosis. Osteoporosis is chronic. Osteomalacia may be episodic, may be acute, possibly could be fixed. Now, in Paget's disease, rather than breaking down bone, what happens here is that there is kind of spontaneous or random deposition of bone very quickly. So you get areas that are hypermineralized or hyperdense. And then the body quickly realizes this isn't normal. I need to fix this. And then bone degradation happens as quickly, happens just fairly quickly as well. So this poor bone is just a mess. So on the left-hand side, you can see a nice, healthy fibula and a tibia with the knee flexed. The white outlines tell us that the cortical bone is pretty healthy. That shadowy inner part here tells us that the spongy bone's pretty healthy. Now, if you look at the fibula over here, you can see that the interior part of the diaphysis, which should be a little less dense, isn't. And if you look especially between where the black writing is, there's definitely some jagged edges on this bone. The white that you see here indicates that there is swelling in this area. You can also see, if you look at the margins of this bone and follow the cursor, that bone deposition has been very disorganized. And in this area here, it's especially thick, which again, the body is going to think of as this is a problem that I need to fix. In the lytic area here, remember that lysis means bursting or breaking. In this lytic area, we're seeing significant breakdown of the bone. And in fact, the cortical margin, the dense bone margin here, is virtually absent. So this bone will be subject to fracture because it's incredibly strong here, more so than it needs to be, not as strong here as it needs to be, and certainly not as strong here as it needs to be, which would be right at the pivot point if you were torquing or twisting the bone. And one last group of skeletal abnormalities are the abnormal spinal curvatures. A scoliosis, and this is a very severe scoliosis, is an abnormal lateral curvature. The kyphosis, which I talked about earlier, is, in this lady's case, she has what's called a dowager's hump. In this case, there's likely been spontaneous fractures or compression fractures here in the thoracic spine, which has caused an exaggerated thoracic curve or an exaggerated posterior curvature. And then in the case of this pregnant woman, this hyperlordosis is not really unusual in a pregnant woman. So if you consider the center of gravity used to be here, right about along the plane of her arm, and now it's moved significantly toward the anterior, so too follows the curvature of the lumbar spine.